like to summarize a couple of things that I have heard. I'd like to first start with Jennifer, who shared an immense amount of information with us about one person's journey in this pathway. And part of what I heard Jennifer speak to was the possibility that the initial diagnosis, psoriatic arthritis, was missed. And I think it comes to the heart of this question for this session of what is TMD. Psoriatic arthritis does fit within that rubric, but if a clinician does not have an index of suspicion for that as being a differential diagnosis, but focuses exclusively on what we think of as the common TMDs, then that diagnosis will be missed.
And I even said to my rheumatologist, do you think that my psoriatic arthritis could be an aggravating factor? And he said, no. And then I pulled up studies that showed that the TM joint could be the first joint affected by psoriatic arthritis, that there were studies. It's not a science he's interested in. So until you find a rheumatologist who's interested in studying the TM joint, it's pointless to argue with your doctor.
Which then highlights the second point, which is a necessity for training. And training that allows us to integrate across multiple systems. The third thing I heard you speak to was something that medicine deals very, very poorly with, and by medicine I also include dentistry, and that is the personal suffering of an individual. The knowledge that Dan and Bill shared with us is more recent information, but it also highlights the necessity for understanding pain. Even when we're thinking about a local condition, and it is this contrast between the local condition and what you were referring to, Dan, in terms of widespread pain, fibromyalgia-ness, the nociceptive centralized kind of pain. It is that continuum or dimension between these two very different kind of poles that I think lies at the heart of the question that the committee is trying to explore at this point with our question, what is TMD? And so with that as a summary, I'd like to open up this session to questions from the panel.
That's it.
Thank you for sharing your long and difficult, challenging journey. Just wanted to understand, if you could give us your perspective of the different specialties of medical providers who were involved in the care over the years for you.
So it's interesting because I wanted to add that to my presentation, but time didn't allow for it, so I'm glad you asked the question. So in my arsenal of doctors includes a pain management doctor, a dermatologist, a rheumatologist, a psychiatrist, a psychologist, orthodontist, oromaxillofacial, acupuncture. I mean, the list is exhaustive, even where you would have to count my gynecologist as part of it because the medications create a fungal infection, which he has to then deal with. The pre-medication that I have to go through just to get a dental cleaning. So I have to go to my primary care doctor to get antibiotics before I can go get my teeth cleaned. So I spend my life running from doctor to doctor to doctor, just orthopedists, because of the other joints that are affected because of the psoriatic arthritis. And then the fact that I'm on permanent disability, I take Humira for the psoriatic arthritis, which is a very expensive drug. So then there's a lot of time spent in doctor's offices that I might not necessarily go to, but they're willing to give me medication at a reduced rate. So it runs the gamut from top to bottom: dentist, orthodontist, neuromuscular dentist, mental health professionals, neurologist. I had an AVM removed, which they found through all of my TMJ surgeries. By doing an MRI, they found that I had an arteriovenous malformation. I had a craniotomy, which again interrupted all my jaw surgeries because they intubated me for 12 hours, which is another question I have, which is, are we training anesthesiologists about when you intubate a TMJ patient not to destroy a joint that's been worked on? So there are a lot of questions that I have, but I was trying to respect the limits of time.
Jennifer, could you just note for the committee this first chief complaint you had?
Well, you asked me that, which I thought was interesting, because that's the question everyone has, is like, when did this start? I was 13 years old. I couldn't tell you. I must have told my mother that I was in pain. She heard a pop, she heard a click. In her mind, that wasn't normal. I was asymmetric, and I complained of headaches. So she took me to a neurologist, because at the time, my headaches were in the temporal region, and she assumed that I was having headache pain, and we went to a neurologist who did an MRI, and who then sent me to Parker Mahan at University of Florida, who sent me to Dr. Piper, it just turned into, right, this cycle of chasing for an answer. It's like chasing a high. You're chasing a solution, and you'll go to anybody who somebody suggests.
But it was a chief complaint of generalized pain in the head and neck.
That's what my mom says. Again, I'm 45 years old. I was 13 when this thing started. So I said my knee hurt when I was 11. I had knee surgery. I don't remember. But yeah, I suppose it was pain.
One thing we can do is when you have a question, just put your name up, and then we'll recognize you.
I'd like to thank you for such a powerful statement. And one thing that struck me, and it also rang through with the other presentations, is the enormous amount of emotional suffering that occurs. And I thought you were so eloquent about how that builds over time. And I wondered, based on your experience, what are the things that we can do to reduce, to identify that suffering early and to reduce it? What are your thoughts on that?
In my personal opinion, I think just building awareness that this is a real disorder, that this is not some made-up catch-all phrase for people who have some pain, because anytime someone says to me, why are you having surgery, and I even utter the 3 letters TMJ, 62 other people in the room go, me too. And I don't dismiss them, because I'm sure they do suffer in pain, but there's levels of TMJ dysfunction, and I think we need to make sure that patients are taken seriously so that they're not dismissed as loonies. Because plenty of people looked at me as like, it's in your head, it's psychosomatic, it's stress, go for some biofeedback, and dismissing somebody is demoralizing, and it makes you feel like you're less than deserving of real medical attention.
David?
So, Jennifer, sort of as a segue to that last response, one of my questions, you mentioned the difficulty you had with insurance coverage, and that's certainly one of the things that can be demoralizing in terms of lack of recognition. And this is jumping ahead a little bit, but we are interested in those issues, and I wonder, would it be, is it inappropriate for me to ask if we could see some of those coverage determination correspondence pieces?
Oh, I have.
Because I don't ask that to call out any specific physician or any specific insurance company, because I think that coverage policies are likely to be very similar across the spectrum.
No, I have everything actually in my briefcase in the back of the room. And I also have letters begging doctors for forgiveness of their fees, and I also have letters from doctors saying, we won't even put your surgery on the books until you pay the entire fee up front. So most doctors who perform this surgery don't accept insurance, so it's a moot point.
Right, but and conversely, there are also insurers who don't provide coverage, and so I'm just interested in getting some color around that from an individual patient perspective.
Do have
if that's not an inappropriate question.
And I'm happy to share, because I happen to be on Medicare. I'm permanently disabled according to the government. I am on SSDI, so I am a Medicare recipient. So Medicare denied my last surgery that Dr. Mehra at Boston University they said that this is considered impacted, anything that has to do with teeth and jaws is excluded from the policy. And I am happy to provide that letter for anyone to see, that it was denied by the government, by Medicare.
Okay, great. Thank you.
Okay.
Kathleen?
All right, so I think I heard Jennifer say this, and I've heard, I think I may have heard Bill, but maybe you can elaborate a little bit. But things seemed, in the progression of the disease itself, they seem to start out relatively local with maybe a single problem or a single entity. Maybe it's a little nociceptive, and then over time that progresses. Do you think that people change their kind of phenotype and process over time, and can we identify, and is there any data out there that if we can prevent that? Kind of both those lines. There's this progression, and can we get people early and prevent things over time?
One of the things that I wanted to bring to light was on my timeline, it shows I had a lot of implants, silastic and proplast implants, that exacerbated the problem. So that's something that probably should be addressed in going forward.
Okay, well, so we have, I think, impressions as to whether there is this concept of a progression from acute to chronic, and whether there's certain mechanistical factors that are related to susceptibility and resiliency. And to be honest, I think there are very few, if really any, studies that have been specifically designed, with, I think, the exception of Opera 2, which is underway now, and as far as analysis and publications, and actually Gary Slade later in the program may speak to that. But the concept of this, if you will, linear progression from, say, group 1 to group 3, we don't know. We believe that there are, within the groups, individuals who are susceptible and individuals who are resilient to changing their cluster assignment. So until there are really well-designed studies that can track folks longitudinally and to track factors, including treatments, that are influencing migration from acute to chronic or chronic to acute. So I think this is really a bidirectional. I can just tell you that our own experience with about 1,000 patients from our Briar Creek Clinic, where we are following cluster assignments over time, we do see the individuals going back and forth between clusters. And whether that's being driven by life history between appointments, whether that's being a result of our treatments, we don't yet know. But I think it's a very important question. But I do think it's a bit naive and the pain field is sort of in this trap right now, that there is this progression from acute to chronic. Well, in fact, there's some resilience factors which are pushing people back, and so the dynamics, the natural history of our patient populations from onset of a condition, factoring in the environmental events, really we don't have that fundamental data allowing us to address that question. Kathleen?
Can I address that, Kathleen? Because there are actually a couple studies, but I would agree with Bill that there's a dearth of data and we need more. So there's a really nice study that was done in rheumatoid arthritis that looked at people in an early RA cohort. These are people that we're trying to identify rheumatoid arthritis early now because we have really good drugs to treat. And unfortunately, if those would have been available to you, right? But again, that would have been better if it was given to you at age 13 than. And what they show is that in that first year of a rheumatoid arthritis patient first diagnosed, they have the same rate of fibromyalgia as the background population, about 4 to 6%. Then if you follow them, about 6% will develop fibromyalgia in the second year. Another 6 will develop it in the third year. And then it sort of levels off at around 20 or 25%. So over 3 or 4 years, there very clearly is a progression from people that have a more sort of nociceptive pain to that they've superimposed the more centralized or augmented pain. You see the same thing very clearly in cohorts of sickle cell disease. We do work in sickle. The young kids with sickle cell disease have purely nociceptive pain. Every adult with sickle cell disease has this. Has the widespread pain, and they're opioid non-responsive and things like that. So I would agree with everything Bill said. I think people move back and forth, and there are some forms of central sensitization that I think are more top-down and others that are more bottom-up. But I do think that some central sensitization is being driven by ongoing nociceptive input. And in that instance, we have to try to reduce ongoing nociceptive input to stop the central sensitization.
Okay, and we'll take a last question from Sean.
Thank you. Jennifer, I similarly want to applaud your courage for coming and talking about your story. I want to call out one aspect that really resonated with me, and that was the degree of social isolation that you have experienced. And particularly for the committee, the concept of a biopsychosocial model is ingrained in all of us. But I would submit that we frequently give the social aspect short shrift. It's often big B, it's getting to be bigger P, but I think it's still small s. And when I was listening to you over and over again and hearing the degree of kind of invalidation of your problem, the impact it's had on you and your family and your friends, that just really struck very strongly. And I see that as a physician scientist who takes care of patients. I'm focusing more and more on that social thing. When you dive in, you see just what a huge impact it's having on people's lives. So thank you for sharing that. Dan, I want to put you on the spot. Bill followed you, so he had a chance to respond to your presentation and kind of nicely pull in what his model of clustering, if you will, and forgive me for being reductive, but his elegant model of clustering kind of tied in with your model of this pain as a continuum. And I'm interested how you would respond to that. And what I'm really looking for is the grand unified theory here, the simple explanation that brings both of these models together, if it is at all possible. Is there a parsimonious explanation for all this?
I mean, I would agree with what Bill said. I don't think these are, I think we had different ways of coming to the same conclusion, but I think the conclusion is fairly similar. Probably the only thing that I ever take offense with that Bill says is he continues to put somatization in the psychological category, and the people that have the original construct acknowledge it doesn't exist anymore. What used to be called somatization is this. And it has very strong biological underpinnings. It's sensory amplification, and again, somatic awareness is sensory amplification of what's going on throughout your body. So that's probably the single thing that I disagree with. And one of the reasons that, again, I say study psychological factors separately, because if you look at classic psychological factors like anxiety, depression, catastrophizing, those are only weak predictors of the development of TMD and OPRA, or weak predictors of the development of fibromyalgia in population-based studies. These are not, they're very weak. Having a sleep disorder in the population is a more powerful predictor of developing pain than having depression or anxiety. So that's all. Again, we probably agree about 99% of things. But every time he shows that old slide, I say, please, somatization is a term that needs to go away, because this is probably what used to be called somatization by the psychiatric field.
Well, thank you, Dan.
Yeah.
But I also think that we're probably, I think, nearly 100% in agreement, and I'll explain why in a minute. But the concept of the grand unifying theory that Sean has, suggested, I think we may have two equations, and I think that Dan's equation may be more on a continuum, a continuous measure, and he relates it ultimately to something like fibromyalgia. I guess our equation is more digital in nature. So I think that we kind of come to the same endpoints, but we are a little bit more discrete with the clustering algorithm compared to, I think, more of an analog metric that Dan has provided. Let me comment on shortly, but it's a very, very, very important point, this concept of somatic complaint. The OPRA team has struggled for years as to what to call this. We've, used the SCL90R. So we've used some of the terminology associated with the surveys. Yet our belief, and I can tell you that I had a life experience with Kristen Thorenson and Gary Rollman at an ISP meeting all around this concept of somatization. And my view has always been that somatic complaint, somatization, which unfortunately has been put in the psychiatric terms, is in fact a biological construct. It has a biology behind it. In fact, we're finding genetic variants which are associated with the level of somatic complaint. And I truly believe that somatic complaint is essentially a checklist, very similar to your checklist of hypersensitivity of the central nervous system to auditory, to visual, to visceral input. So it's not clear exactly. History puts it in psychiatric terms. Practicality puts it into a totally separate construct, which is sorely important that we understand it further. The last point I would like to make, that our metric of somatic awareness is the single largest predictor, consumes a lot of variance in predicting the onset of TMD and its ability as a metric to discriminate chronic cases from non-cases, more so than any QST measure, more so than any other psychological factor. It is the factor that is several times greater in prediction and discrimination than any other factor, yet we know almost nothing about this construct biologically. And so I think that's an area that I would really advocate that we begin to really tease this apart and to begin to understand what it means.
And as we've seen in the psychiatric literature, they're moving more and more into more of a mechanistic-based approach and trying to move away, I would say, from the DSM clinical classification. And most all of these psychiatric conditions have a neuroanatomical basis. And as we're seeing, for instance, with an example of depression, greater awareness that there are neuroimmune disruptions, in these conditions. So in essence, they all do tie back together.
And that's why they made cluster.
I think this is a good point to stop. I'd like to thank Jennifer, Dan, and Bill for sharing their experience and knowledge this morning. The session will pick up again later today, but for now, I believe we are taking a break.
Yes, so let's just take our 15-minute break and come back at 10 after 10.